Thank you, members, for coming to this special meeting. We have been working rather hard this summer. Let us invite the administration to come in. I'd like to thank the Secretary for Food and Health and his colleagues for coming to this meeting. If you have settled down, Secretary, can you introduce the admin's paper to us? And that is the measures for the prevention and control of the Ebola virus disease, or EVD. Thank you, Chairman and members. In Hong Kong, as you know, we are paying close attention to the situation regarding EVD. The FHBHA and also CHP have already started to work, and we have also conducted experts meetings, and we have also had interdepartmental meetings with government bureaus and departments in order to review our work processes. In order to respond to this, on the 20th of August, in fact, before that, we released a preparedness and plan for coping with EVD. And when there will be a serious impact made to the public health system by EVD in Hong Kong, we want to make sure that we have core capacities in order to quickly and efficiently respond to the threat. At present, the epidemiology situation is that we have already activated the alert level. As you know, in the 4 Western African countries where there is an outbreak, there are no direct flights to Hong Kong, but we cannot rule out travelers coming to Hong Kong have contacted the virus in those 4 countries and have taken transit flights to Hong Kong, or they might have come to Hong Kong through other means. We are of the view that any measures to prevent EVD should be kept in place. Every traveler coming to Hong Kong now will be taken, will have their body temperature taken, and also when they have come into Hong Kong, before they attend immigration for clearance, they will have to go through a body temperature check. Compared to 10 years ago, we have got new equipment for this. If you have been to the airport, you will know. And also there will be people using portable body temperature devices in order to complement the measures that are already taken, especially for those people who are children or who wear hats on their head. We use the portable device to complement the measures. And also, we have already electronized our mechanisms at the clearance kiosks. For those who use West African passports, we will be alerted to that, and therefore immigration officials at the kiosks will come to know that these are travelers from those countries, and they will point these travelers to another desk, and there will be a simple assessment done, and we will ask the traveler what he or she has done in those countries, or whether they have been to these countries, because if they used the travel documents from these 4 countries, they may not have come from the countries themselves, and then we'll give them a direction. And the direction will include the symptoms and other kinds of knowledge on EVD, and there will be 2 important directions. If they already exhibit symptoms, they should alert us immediately so that our port health officials can do an assessment on them. If they do not have symptoms now, but they do exhibit symptoms after coming into Hong Kong, we will also direct them to go to any A&E department immediately, and their travel and also contact history should be made known to medical officers. In terms of the pamphlets, we are doing improvements now because these countries may have people who do not know English but French, and we are now preparing the French leaflet. And we are going to do more broadcasts in the concourses. We are going to extend those from the airport to other land-bound concourses, so that those people who have been to these countries and if they come back to Hong Kong and exhibit symptoms, they are alerted. Because at the immigration kiosk, we can only identify the travelers with passports from the 4 affected countries. But then it is possible that there are people who do not use those passports from the 4 countries, but nevertheless, they have been to these countries and they have taken onward flights to Hong Kong. We have also contacted airlines to do the same kind of broadcasting before the airplanes land in Hong Kong. As you may know, from H7N9 to the Middle East respiratory syndrome, we have done the same for those issues, and now we are designing a kind of broadcast which will include all 3 notifiable diseases, because sometimes we need to do it in a few languages, and if we do it separately for the 3 diseases, it may be quite complicated. So we are now consolidating the broadcast message for the sake of the airlines. As for suspected cases, there was 1 suspected case reported, and we have consolidated our experience in handling it, and we are now making improvements. Number 1, we like to do early identification of suspected cases. FSD officials, if they get a call for help, they will actively ask for more information. If the information shows that there are compatible symptoms of EVD, and also if the patient has been to affected areas, we will make preparation for earlier alert. Now, even if the information may not be available from telephone inquiries, if the ambulanceman should suspect such upon arrival, they can again take protective measures. And also when the patient is ferried to the hospital, the patient may be left on the ambulance for a moment. Now, of course, it depends whether it is an emergency situation and whether immediate or first aid is required. But if possible, the patient will remain on the ambulance, and medical staff with personal protective equipment will do preliminary assessment on the ambulance. If it is a suspected EVD case, we will not unload or allow the patient to alight from the ambulance, but he or she will be ferried to Princess Margaret Hospital Infectious Disease Center immediately. Now, of course, there are guidelines for using PPE under different environments, but we are also going to discuss the various kinds of equipment and also what kind of PPE should be used in what kind of medical environment. We will make some guidelines on those. On the whole, we have already got guidelines, but we think that we can still refine it, because in such a situation, especially if the virus has not come to Hong Kong, then it's one thing. But if indeed it has come into Hong Kong, then Hong Kong citizens and other professionals may know from TV or other places that in other countries people are using other PPE. Then there will be comments on new PPE, and questions will be asked as to why in Hong Kong we do not use certain kinds of personal protective equipment. I think what is important is that at present we already adopt a PPE standard which is in line with the CEC and WHO guidelines. Now, of course, we do not rule out new or equipment that has a higher level of protection and which will have to be used in a certain situation. And if that is really the case, we will define it early so that no confusion will be caused. But I would also have to point out that very often, on the face of it, you may see that the PPE is highly protective, but sometimes there are still problems with those. So leave this to our experts who can discuss this along scientific principles so that a guideline can be drawn up. In terms of medication, I think that more or less the same situation has emerged, because at different stages you will see from the media that in different places there are experts and organizations talking about different kinds of medicine. But first of all, you have to understand that up to this moment there is no drug that can cure EVD and which has undergone thorough clinical tests on humans. In other words, there is no drug which is licensed or which is recognized to cure patients with EVD. Even if in the US, 2 persons have been taken back to the US and who have recovered after using a certain new drug, the US authorities have already pointed out very clearly that there is no evidence to show that the 2 US citizens have recovered because of using that drug. Therefore, on the one hand, we pay close attention to the WHO and other important organizations and the guidelines they release. But very often, the guidelines released by these organizations are at a high level. In other words, they have guiding principles made at a high level. For example, with regard to ZMapp, the WHO has discussed it and has released certain guidelines. But those guidelines are only saying that when there are yet no other ways to cure EVD, and if there is a clinical need, and if there is no other way to tackle EVD, then perhaps we could use the drug which has not been tested on humans, and then which will not be regarded as contravening medical ethics. That is very useful. But then for clinicians, they still have other considerations. When you have a patient in front of you, do you use the drug early or later, and depending on the patient's situation? That is still not clear. And our committee will still have to make reference to literature that can be found around the world, and any drug that has been proposed and which has been tested on animals or in labs and which is said to be effective on EVD. We'd like to discuss all that information so that the guideline will be as detailed and refined as possible.
And I'd like to say once again that, well, when there is a clinical confirmed case, we will have to decide whether to use the drugs and when to use it, and how much information is available for explanation to the patient. Well, it covers many different aspects. Some of them are curative, some others are preventative, with different results and different considerations. In relation to liaison with other places, including the mainland, earlier on, I have had a very good discussion with the National Health and Family Planning Commission on Ebola. Most important area is on port control, but in that regard, we can only identify travelers with passports or traveling documents from those countries, and through dissemination of information, remind travelers who don't hold those passports but have visited those countries. we have established a very effective point-to-point communication mechanism with mainland authorities. So where there are special situations related to Ebola, we will immediately trigger the point-to-point communication mechanism. There are some cities where certain ethnic groups may settle, may be living there, and they may be from these countries, and we will closely monitor the situation. We're aware that the public is very concerned about the Ebola situation. We will disseminate the latest information on Ebola. The HA, the Department of Health, and the FHB will do their level best. And sometimes when we disseminate information, we may not have all the information, but we'd rather adopt a very transparent approach and disseminate as much information we have on hand to the public. I will answer questions together with my colleagues from the Department of Health, the Bureau, and the Hospital Authority. Thank you, Secretary. And I now open the floor for members to ask questions. Alice Mack, Albert Chan, Chen Hangpeng, Albert Chan, Sid Ho, and Anne Chang. First, Miss Alice Mack. 4 minutes each. She's not here. And Mr. Albert Ho. Of course, we have to start to be prepared, and we have to heighten our vigilance. I know that for Macau, starting from the 1st of August, there is a health assessment and a tracking measure in place for travelers coming from those affected countries. And if, unfortunately, there is an outbreak in Hong Kong, what about vaccines? I know that there is one that is being tested. And in the paper, it's mentioned that it may still be under testing, but it may be used. So do you have a stock for that? First, we're aware of the measure of Macanese government. And when it comes to assessment, their approach is similar to that of ours. Apart from identifying travelers by their passports, there is no other way to alert travelers not holding those passports but coming from those countries or have been those countries. They will be reminded that if they present any compatible symptoms, that they should seek medical attention as soon as possible. Tracking is difficult and may not be feasible. That depends on the volume of people that are under the tracking system. And Macau is a smaller place, so it is very different from Hong Kong. And then, as I said, there are many people who have advocated different drugs or vaccines. But so far, there is no vaccine that can effectively prevent Ebola. There are some pharmaceutical companies which have produced certain products, but they are not thoroughly tested clinically. All in all, if the patient is one of a serious case and has fallen ill for a very long time, if you use drugs that have not gone through human clinical tests, maybe there is a smaller ethical issue. But for someone who is healthy, and if the person is given a drug or a vaccine that has not been thoroughly tested clinically for prevention purpose, there is an entirely different set of ethical issues. And so far, we don't have such vaccines anyway, so there is no question of how many do we have in stock. And for some drugs, they are not new drugs. They have been registered, but for a different purpose. And in some places, some scientists or experts have used them on Ebola in laboratories and on animals, and so far no tests on human subjects. And there are signs that it may suppress the Ebola virus. We already have those drugs because they are not novel drugs developed just for Ebola. They were developed for some other purpose and they have been registered. But we have to consider how strong the scientific evidence is. We also have to consider safety risks and other issues. We have to let the experts conduct more tests before we can formulate a clinical guideline. Ms. Alice Mack. Sorry, I apologize. I was out just now. The Secretary said that there is no vaccine against Ebola, so there is not much we can do when it comes to prevention. We hope that there won't be the first case, and if unfortunately we do have the first case, we have to consider how to effectively contain it so that there won't be an outbreak. As the Secretary said, and we've learned from the media, there is no effective drugs to cure Ebola. Is it the case that if we have the first case, a decision can immediately be made to use certain drugs, say for example drugs for breast cancer on such a patient? So when it comes to the use of drugs and diagnosis, are there any plans in place to deal with the first case? Thank you, Ms. Mack. Please understand that there is no recognized drugs or targeted treatment course for Ebola. The most important treatment is a supportive treatment, and its importance should not be neglected. So it is very important to provide clinical supportive treatment. And the second most important matter is isolation, because we need to contain the virus so that it will not be transmitted to other people, including healthcare workers. Well, in Hong Kong, every so often you'll hear something new, and I have asked expert committee to provide a breakdown of the feasibility and the different matters of the drugs and courses of different drugs. And it will be in the end for the doctor in charge to decide which to use. So we cannot set down a protocol as to which drug is to be used on an Ebola patient. So when it comes to treating a patient, all the decisions are clinical decisions. And for the Bureau and for the department, our job is to clarify the procedure, when and if we can use the drugs, and if we can, when we can find the drugs. For registered drugs, it's easier because we can make sure that we have a small stock. But when it comes to new drugs, we have to rely on overseas pharmaceutical companies to supply us the drugs, but they are still being developed. And the companies will put priority on the affected countries. We are now talking with the pharmaceutical companies and the WHO as to where we can find the drugs and get our hands on the drugs. But a lot of countries are asking the same question, and there is an insufficient amount of drugs. So we may not be able to get any. But we are trying to establish a communication channel. But we fully understand that it will be difficult for us to get what we ask for. And Ms. Mack, you can rest assured that we already have a procedure in place, even for new drugs that have not been registered. If the doctor in charge decide to use it, then the doctor can, through the established mechanism, apply to the Department of Health to use that drug. So there is already a way in place. Mr. Chang Hang Pen. There aren't any direct flights to and back between Hong Kong and African countries. Most of them are indirect flights. The Secretary is right. We can use passports to identify where travelers come from. But I'd like to ask, are there any Hong Kong people in the affected countries? They include volunteers, voluntary workers, healthcare workers, doctors. Are there any assistance given to them? And have they approached you for assistance? As you know, that two people from Hong Kong Red Cross, they are stationed in Liberia, but they are not directly involved in frontline medical work. Their main duty involves education and publicity. They have recently arrived in Hong Kong, and we are in close liaison with the Red Cross as to when they would come back, and the Red Cross have informed us, and soon after they have landed, they've been sent to Port Health for assessment, and there are no symptoms, but we have made arrangements for them to be under medical observation in the coming 21 days. Their temperature will be taken, and as soon as there is a presentation of symptoms, we will follow that up. We also take the initiative to communicate with medical voluntary workers or missionaries. We're aware that the MSF, the Médecins Sans Frontières, have someone there. But of course, we don't know exactly what happens, because we're trying to get the information, but we may not be able to find out everything. But we will liaise with organizations that have teams sent in the affected countries. We know that every day there are some people from Africa or West Africa. They arrive in Hong Kong, and on arrival they will have to fill in a health declaration. No, we don't require all inbound travelers to do that. But that is the case in the past, and that is also the practice of a lot of countries, including Korea. Inbound travelers will have to make a declaration, and on the declaration you will have to write down your residential address. And well, in the past, if you've just put down hotel, you'll be allowed in. Given the situation, would you put in place measures to require inbound travelers coming from Africa to make a declaration and require them to provide their genuine residential address and contact telephone numbers so that they can be tracked? This has been floated early on. During SARS and H5N1, we have considered that, and according to our experience, is not very effective.
Because even if you give a form to the people, you still have to have the travelers cooperate with you. before they will actively give you the information. So we think that this is not an effective measure. Number 2, this will have to involve a big number of people traveling into Hong Kong. And number 3, we may actually create a situation of cross-contamination, because if we distribute all the forms on the plane, and if it is found that the forms are not filled in, you still have to give them the forms again at the immigration desks, and you have to give them the paper and pens, and these people have to gather at a certain place, and people from different flights will be gathering at the same point to fill out the forms. And there will be an opportunity of cross-contamination if one of the travelers is infected. So any means that can be thought up will have pros and cons, and at this stage I will not consider doing this. Whatever is for the future is another thing. Well, Secretary, I'm not talking about all travelers. I'm only talking about those who are from affected countries or areas. If they can be traced after they come into Hong Kong, then are you going to consider it? Well, I have already handled this matter. I have answered the question from another member who asked about the Macau situation. Next, Dr. Helena Wong. Thank you, Chairman. We have received news that there are more countries which ban travelers from 4 Western countries from entering their areas. This goes for Kenya and also South Africa. The WHO has listed this as a public health emergency of international concern. I thank the chairman for calling this meeting. So we have some explanation from the experts. The US CDC has also issued the highest alert to US citizens, and that they should not travel to 3 Western African countries if not absolutely necessary. Taiwan and South Korea have issued the same kind of travel alert. If we look at the US highest level of alert, I think it can be likened to the red outbound travel alert of the Security Bureau. In other words, don't go to those areas if not absolutely necessary. But in Hong Kong, the OTA is in 3 colors, black, red, and amber. But then Ebola, EBD, is not included under any of those levels. On the website of the Security Bureau, in fact, you have also mentioned this in the paper. You say that the Health Department has already posted an important notice on the Security Bureau website to say that the Department of Health will advise travelers to avoid going to Nigeria, Liberia, Sierra Leone, and Guinea. Why is it that this important notice from the DH is not included into any of the OTA levels? Is it that the DOH cannot convince the SB that EVD may pose a personal safety risk to travelers? Secretary, can you help us understand the situation? Number 1, the banning of entry. The WHO has not proposed this measure against the affected countries. Now, of course, we understand that there are places which have direct liaison of more frequent direct liaison with these affected countries, and they have done this, and it is not for me to comment whether what they do is right or wrong. But for Hong Kong, I think that at this present stage, we do not have to ban the entry of people from those areas. Number 2, the OTA, if you look at the CHP or SB websites, a very prominent positions, you can see what Dr. Helena Wong repeated, and that is to advise our citizens not to go to these places if not absolutely necessary. Whether the U.S. has already issued the highest level of alert, it is not for me to comment, but you can see the same kind of message as detailed by Dr. Helena Wong. In other words, if not absolutely necessary, you should not go to those areas. And the SB3 color OTA is really targeting security. But we are talking about health. And I am of the view that we really do not have to talk about the differences between the two. I think the message is clear and the same. When you go to those websites, people of Hong Kong will see those messages, and I think that is important. Can I please clarify? Can you wait? I think your time is up. Mr. Albert Chan? Chairman, I'm concerned about our preparedness and contingency plans. At the time of SARS, our response was not good enough. So frontline medical staff met up with a disaster, and medical staff actually lost their lives. In terms of preparedness and a response plan, if indeed a patient comes to Hong Kong, what is the kind of division of work like amongst medical staff? Which hospital will be the first hospital to receive the patient? And also, do you have adequate training given to medical staff? And what will be the streaming arrangement like? We want to prevent the previous situation of SARS because frontline medical staff bore the brunt. If there is a suspected case and if somebody exhibits the symptoms, what will happen? Last time, when the ambulance went to Chongqing Mansion, there is already a lot of criticism against the handling of the suspected patient by ambulancemen. So if there is another suspected case, from the ambulance journey to the hospital, do you have already got a mechanism, and have you already provided training? Can you please explain this to the public? And if somebody exhibits such symptoms, which hospital should they go to? Let me answer your second question first. I'd like to give the opportunity to Dr. Lau to tell you about the preparedness of the HA regarding your first question. I think I have already said just now that the principle is to have early identification of suspected cases. The principle is if a patient presents himself at an A&E department, then we'll have to do the triage at the A&E department. The triage nurse will take care of this. And earlier on, I went to one of the A&E departments, actually the one at PMH. I could see that at the triage station, our medical staff are already equipped with the PPE. They will receive the patient and do an assessment. Of course, during the assessment, if any infectious disease is suspected, there will be trigger of the right kind of protocol. And if we should ask the FSD for help, then right now, because of the handling of the first suspected case, the FSD will actively ask for more information. If the information should show that the patient has exhibited compatible symptoms of EVD, and if the patient has been to affected areas, then before the ambulance arrives on site, it will be put on the alert. Even if the information is not available on the telephone, if the ambulancemen arrive on site and there is suspicion, then they will take the appropriate protective measures before they will handle the patient. Now, of course, the patient will be taken to the nearest A&E department. At present, the principal is to take care of the patient's interests, and so he will be ferried to the nearest A&E department. Upon arrival at A&E, if the patient's situation allows, he will stay on the ambulance, and medical staff with PPE will go up to the ambulance to do early assessment. But if the A&E department is not at PMH, and if after initial assessment. If it is a suspected EVD case, then the patient will be taken in the same ambulance to the PMH. Sorry, Chairman, I don't have time. When there is time, maybe you can ask Dr. Lau to explain how HA will tackle the situation. Well, actually, this is very important. I have given a lot of time to the administration to answer my questions, but the Secretary has taken up all the time. Actually, the thrust of my question is about the response measures. There will still be time. Well, I may not be able to stay till the end of the meeting, but we are only giving 4 minutes to each member. I asked a short question, but Mr. Secretary took a lot of time. No, you can hear that I have already tried to speak as quickly as possible. Ms. Ann Chang, South Africa said today that people from 3 affected countries will be banned from entering South Africa. They are in the same African continent, and they have had quite cordial relationships, but I think South Africa has assessed the situation to be dangerous, so it is banning the entry of people from 3 affected countries. Well, within a matter of months, there have been 2,000 odd cases. How many people have recovered? We don't know. But we understand over 1,000 have died. Is it that the rest have been cured, or are they being cured? It's just that they have not died. Is that the case? Maybe you have the numbers. I heard from Dr. Koh that we do not have medication, and investigatory medicine may not be supplied to Hong Kong. In other words, if in case EVD is in Hong Kong, we have no medication. The question is, when the patient should appear, the symptoms may be very much like the influenza. First of all, you may have a sore throat, a fever, a runny nose, etc. They are very much like influenza symptoms. And then in the second stage, of course, there will be vomiting. But during that time, the patient may infect many people. And to allow the public to have a clearer understanding, is it that this can be passed on by sneezing, or is the virus airborne, and how is infection affected? Please tell the public, because they travel, and when a suspected patient is discovered, maybe he has already infected many other people. Can you tell the public more? Thank you, Ms. Chang. Can I ask Dr. Leung to answer the question? Which doctor? Mr. Leung Teng Hong.
The EVD transmits through direct contact with body fluid or blood of a patient. Well, our skin is a very good barrier, so if you touch it with your hand on the patient's skin, you will not get it. But however, if there is contact with mucous membrane or broken skin, it can be transmitted. But the disease is not airborne like general influenza. So the transmissibility is a lot lower than a general influenza. Incubation period spans from 2 to 21 days. Before an onset, when it is asymptomatic, it's not transmittable. As far as we know, that the fatality is about 54% out of the 2,000 cases or so. I'd like to say that very often in Hong Kong we have African people claiming making torture claims or refugee status. They stay in Hong Kong, and we don't know where they're from. West, East Africa. So we have to strengthen are checking at control points. Yes, your time's up. Next, Ms. Sit-Ho. Ms. Chang rightly pointed out that mainland may be a place where we will get the first case, because they have contact with East Africa. In Hong Kong, we don't have frequent flights with East Africa, but however, when it comes to Middle Africa, there may be people traveling from there to the mainland, and then they will travel to Hong Kong. Is there a clear and effective mechanism to exchange information? What I'm concerned is that well, last time with SARS, there was a serious outbreak in China, but we were not fully aware of the situation. However, there were signs, and still officials did not treat it seriously. I asked the administration to take on board the experience of SARS. Consider whether mainland travelers will be coming, might be coming from Africa, or they have been to Africa. I read from a press release of the government that when a patient has recovered, the virus may still survive for 7 weeks inside the patient. Well, if you talk about transmission by body fluid, and sometimes, say for example, you get in a taxi, you see that there is a piece of tissue paper stuck in the taxi. Can it be transmitted in this way? And we've learned from the news that in a West African country, a clinic was looted, and people even grab blood-stained linen. Can it be transmitted in this way? Can you find a comprehensible easily comprehensible way to disseminate information to the public? Give specific examples to tell the public how they can protect themselves. What if a visitor stays in a hotel? Would there be a repeat of what happened during Donald Tsang's time, that the entire hotel has to be closed down? Well, it may be the case that it's not airborne, so it may not be as highly transmittable. But still, apart from being transparent, you have to explain to the public in a simple and easily comprehensible way. Secretary. Since SARS, our publicity and education have been very effective. We draw the attention of the public on personal hygiene and environment hygiene. The doctor mentioned about mucous membrane, eyes, nose, ear, and the way to bring the virus to these orifices is our hand. And I think the information is very different nowadays compared with SARS, the time of SARS. A lot of people nowadays understand that if your hand touches something, you will have to clean it. And you will find a prevalence of rubbing alcohol available in a lot of places. I won't be using medical jargons every day when I explain to the public the situation. And when it comes to the mainland, as I said, that a few days ago I had a meeting with the National Health and Family Planning Commission. There are some cities where ethnic groups from the affected countries stay. And since SARS, we have a point-to-point notification mechanism where there is any change of the situation. We will use the mechanism to exchange information about Ebola. Next, Mr. Chen Kim-po. Can the Secretary explain to us? You talk about supportive treatment. What are the details? Does it mean there is no treatment? The second point, well, there are risk levels in different places. Say, for example, in Chongqing Mansion, there are a lot of African people gathering there, and in mainland, and there may be a similar situation. Last time in SARS, the first patient stayed in a hostel. So, is there a risk that it will be transmitted in a similar way? Secretary. First, a possible, what we have done in relation to buildings or areas where there is a large amount of people, a large amount of ethnic minority of that group living in. We have visited Chongqing Mansion more than once and Mirador Mansion once. These places are popular lodgings of African travelers. We, through landlords, distribute information to the travelers. We have also arranged talks for persons in charge of these guest houses. We have also contacted African ethnic groups in Hong Kong to disseminate the information. We will continue to liaise with these groups. Next, Hospital Authority. Dr. Au, I'll spend about a minute to answer the question about the response. It's slightly different from MARS because at this time we're very much aware of the characteristics of the EVD, and we have quite some time to make preparation since end of July. And during SARS time, we have established a notification mechanism, and we also have a system for PPE. When it comes to PPE, it's different from SARS because we have to strengthen our PPE vis-a-vis the characteristics of the EVD. We have increased our stock, and by the end of August, we will have everything. We will almost have everything we need. And in relation to the mechanism, it's in relation, we will use the central committee on Infectious Disease and Emergency Response. We have worked with the CHP on the definition of prevention, and the information has been disseminated to frontline healthcare workers. When a patient visits the A&E department, currently we have designated the Infectious Disease Center of the Princess Margaret Hospital as the main center. And there are coordinated efforts with other departments. If there is a suspected case in the ambulance, an assessment will be done, and the patient will be directly transferred to an isolation ward. And in relation to supportive treatment, in short, well, maybe I will give you some time to continue later. Ms. Priscilla Wong. I heard that there is a fertility rate of 54%, which is high. And I've learned from the press that Ebola may reach Hong Kong is on the front page. So Hong Kong people are worried. And in Guangzhou, there are some news about someone bleeding, and the dressing was put on that injured person, and that the helper was worried. And there are also news about certain athletes being banned from participating in games. If the public don't know what is going on, it is undesirable. And I've read in the paper paragraphs 2 and 3, in particular paragraph 3. Close contact with the blood, secretion organs, and other bodily fluid of infected animals. What do you mean by organs? Well, when it comes to avian flu, you know that you should not touch certain organs. There are some dog lovers in Hong Kong. What are we supposed to do? Sometimes we are very close with our pets. What about bodily fluid? Do you mean sweat as well? It's rather vague. And skin. What about say asthma? For SARS, it's upper respiratory disease, so you will usually go to an ERN doctor. What about EVD? Would you, if you exhibit certain symptoms, would you usually go to a certain type of doctor? I have always have with me masks, 10 or so. But on an airplane, if you ask for a mask from the crew, usually they won't have any. What if a passenger only find that he or she is presenting such symptoms after he or she has boarded the plane? Would there be some clear measures in place? And in relation to notification mechanism, well, the disease first started in Africa. Prevention is always better, so we have to learn from our past experience. So all the way from a kindergarten to cabin crew on airplanes, what about measures? Can we have some more information? Well, in relation to information, I will start and I'll defer to Dr. Leung for policy. Ever since there was an outbreak of Ebola in West Africa, I have not counted how many times we have taken the initiative to disseminate information. If you say that we have not done our best to disseminate information, that is not the case. We have done our best. And of course, there is always room for improvement, and we will strive to improve. When it comes to the mainland, as I've said repeatedly, we have an agreement, an highest level agreement. We have already have a point-to-point notification mechanism in place. And for the other areas, I would defer to Dr. Leung. What about people coming from Africa? But in short, if you sit next to a patient, you will not get it. And if the patient has no broken skin, it will not be transmitted. The means of transmission is that, well, if your hands are dirty and then you touch your eyes or your ear, your nose, then yes. But if there is no broken skin, it will not be transmitted. Contact with blood or bodily fluid. Well, in the blood, there is the virus. Bodily fluid, it increases secretion, urine, sweat, and feces. So after coming into contact with that, you will have to clean your hands, wash your hands before you touch your eyes, your ears, and your nose. So frequent washing of hands is an effective prevention means. There are some unanswered questions. Masks. And supportive care. The mode of transmission is not through air, it's not airborne, so there is no need to wear a mask. When you deal with the vomit of someone, there may be droplets or splashes. You may need a mask, but no, normally you don't need one. Well, you will encourage airline operators to provide masks. You will have to wait for the second round. What about supportive care? And that is also very important. Please elaborate. Perhaps I would defer to the HA clinical staff. There's nothing new under the sun.
Okay, let me continue to give a brief introduction the virus can be very pathogenic. It can kill your resistance, and the organs of the body can be affected during the process. By supportive treatment, we mean that when clinicians care for the patient, they will see what can be done to support the organ functions so the body can recover and also can tackle the virus itself. So when we talk about supportive care, it includes a wide range of treatment, including treatment at the ICU. Talking about medication, sometimes the medication is tested on animals, and it may be found that the medication can help the patient recover. But then our medical experts have to hold further meetings to discuss what medication may be available. Maybe Dr. Zhang can talk about clinical supportive care. Which Dr. Zhang or Dr. Ao? Let me say a few words. The known death rate is known from underdeveloped countries where the medical conditions are not ideal. These countries may not even have intravenous fluid treatment, but then in Hong Kong, this is not the case. Now, if there is hemorrhage, we may have to transfer blood, and we will have that kind of medical treatment. Maybe Dr. Zhang can say more about supportive treatment. Thank you, Chairman. There are a few stages for this disease. As members have said, at first it may be very much like influenza, like a fever, feeling listless, and body ache. At this stage, the supportive treatment may be for painkillers or maybe Panadol. But when the disease develops, there may be diarrhea or vomiting or loss of balance. Then we may have to give saline, and also we may have to give oral rehydration with solutions containing electrolytes, and then he may need blood platelet transfusion. And if there is multi-organ failure, then the patient may need ICU care, and ICU medical staff may need to see which organ is failing. If it is the lung, if the patient cannot breathe, then there might have to be intubation, and if the kidney loses its function, we may have to give the patient dialysis treatment. You still have some time. In the U.S., medical conditions are quite advanced, and therefore the 2 U.S. citizens have recovered 100%. Is it that the patients just have to toil through the process and recover by themselves in the end? Do you have the information, Dr. Ao? Indeed. Well, in developed countries where there is modern medicine, we don't see many cases yet, so we cannot draw any conclusion. Like the 2 U.S. patients, they used one medication, but then is it that because of the medication they recovered? The same cannot be said about the Spanish priest. So we cannot draw any conclusions because of the small number of cases. However, if there is good supportive care, if this is contrasted with the lack of any basic supportive care, the situation can be very different. I still have a second round with many members raising their hands. I think we can still allow each member 4 minutes. Dr. Helena Wong. Chairman, I was talking about the outbound travel alert. Of course, I understand that there is a 3-tier OTA made by the Security Bureau. I understand this is done on the basis of personal safety. But it seems infection outbreak is not related to personal safety. Of course, we understand that from the Bureau's paper, EVD has yet to find a confirmed effective medication, but then the death rate is 54% and 1,350 people have died. This is a very high death rate and many people have died. How can you say that this is not related to personal safety? The concept of personal safety should include an infectious disease outbreak. Personal safety should include health risk and also life risk arising from a disease outbreak. Well, it is good that the DFH has issued the advice. According to the advice, I think this can be likened to the red OTA of the Security Bureau. Is that right? And if that is the case, then the different bureaus should sit down and talk and maybe review the OTA of the SB so that it can be linked to the FHB's consideration of life and health. Because when travel insurance is taken out, people may want to consider following the OTA of the SB, and that is, if you don't follow that advice, you may not be able to claim compensation. However, if the DFH issues some advice which is outside the OTA, there may be arguments vis-a-vis insurance cover. Do you think you should talk to the SB? Well, I have no particular views on this one. What is important to me is what I said, that the message is we have issued is the most correct message, and other countries are using the same message. So we have issued that advice, and our concern is public health. So we have issued the advice, and I think that is appropriate at this stage. This is what is most important to me. Then does it mean that the Secretary is of the view that there is no need for the administration to do a review? Well, I do not have any particular view at the moment. I'm not saying your advice is not appropriate, but if you look at the wording, I think it can be equaled or equated with the red OTA. I have said that I have no particular view at this moment. Chairman, can you write to the SB and let them know our discussion today? Ask the SB to liaise with Dr. Koh to ask whether infectious disease outbreaks should be subsumed under personal safety. If Dr. Koh will not want to take the initiative to talk to SB, then perhaps our panel can ask the SB to liaise with Dr. Koh. Or is it that there is no need to do this? Chairman, I have a very close and appropriate liaison with the Secretary for Security. And in fact, this is the product of my direct communication with the S4S. Well, if that's the case, can Dr. Koh tell us your understanding after talking to the S4S? Why is it that this is still not incorporated under the OTA? Well, I will say again that my concern is the citizens' health. So the advice is issued for the protection of public health, and in this situation I think that advice is appropriate. Chairman, I don't agree with Dr. Koh. Of course we are concerned about the public health, or else we should not be holding this discussion. But now that you separate the two kinds of advice, would you give the impression to the public that they should not have such a high degree of alert? Dr. Koh said he did not agree. Well, I think you are proposing that we should write a letter to the S4S. I will think about it and I will let you know how I'm going to handle it a moment later. Ms. Alice Mack. Chairman, I am more worried about people in Hong Kong and people coming into Hong Kong more than those who leave Hong Kong. If a traveler should come into Hong Kong or a Hong Konger should exhibit the symptoms, then the SFH has said that throughout the world there is no medication, particularly for EVD, and we can only provide supportive care. And what is most important is isolation. But that is exactly our worry, because I think if my memory serves me correctly, when we had SARS, we did not have the PMHIDC. Now, have we done any evaluation if there should be an EVD outbreak in Hong Kong? What will happen with the IDC? You are saying that any suspected case should be taken to PMH. I understand you have a plan that the patients can be taken to other hospitals after PMH, but what is your plan? What are those steps? Also, during isolation, again, I can think of the very painful lesson from SARS. There was isolation, but then the medical staff who handled patients in isolation were also affected. Some have survived, but maybe they were using medication that caused AVN and they are still suffering from the aftermath of that kind of medication. So do we have enough space and facilities for isolation if there should be an outbreak? And also staff-wise, would it be like SARS again, that we should ask the auxiliary medical staff to handle patients? I remember last time we arranged for people to be isolated with the help of auxiliary medical staff, and some of the staff members were consequently infected. So if there should be an outbreak, what are the plans in terms of space and facilities? Well, actually, when we talk about isolation, there are two different situations. One, the patient is taken to a hospital and we should house the patient in an isolation ward. Before SARS, we had a very small number of isolation wards. But today, in the entire HA, we have 1,400 isolation beds. Ms. Mack mentioned another kind of isolation, and that is for those who are defined as people in close contact with a confirmed case. These people may have to be isolated for medical surveillance, but that is a different situation. We may make use of holiday camps to house these people, and we have also improved the facilities at holiday camps, especially hygiene facilities. We also have a mechanism to tackle a certain number of people who have close contact with a confirmed case and yet they need not be hospitalized. And we can already trigger that kind of isolation arrangement in a very short time. Ms. Mack also mentioned if there is a serious outbreak, do we have enough facilities? Well, I think throughout the whole wide world, no medical system can answer that question, because the goal of our preventive measures is that we can do something at the early stage, and that is when we still have a small number of confirmed cases, we can isolate the patients so that we can control the situation at an early stage. So I hope we won't have to count whether the 1,400 beds will be enough to tackle the situation. Ms. Sit-Ho, I'd like to follow up on one part of my previous question. I'd like Dr. Koh to explain the situation for the sake of the public. In your press release, it is said that after recovering, you can still allow the virus to survive in you for 7 weeks, which is a long time. This was the press release on the 19th of August. It was from you. 7 weeks is a long time. After the patient recovers, he enters from the airport, and even if you take his body temperature, you will not be able to detect anything because he has already recovered. But please tell the public, a recovered patient, if he still has the virus on him, what is the chance of the virus being transmitted to other people? Is it that his bodily fluids can still infect other people? And if upon entry into Hong Kong you cannot tell from his body temperature, then what prevention can be done? I think Ms. Ho has made a very valid point. That is actually what will happen. But then, clinically speaking, a patient who has recovered is very different from a patient with symptoms. If the patient has symptoms, he may have vomiting and he may have bleeding, and also his upper respiratory tract and in digestive systems may have symptoms, but then a recovered patient should not have symptoms. And indeed, the virus may still survive in him, but it is only through very close contact, like a sexual contact, that there can be infection. But a recovered patient must have been examined by our medical staff, and upon discharge from hospitals, will explain to him that he should be able to do certain things and not other things during a certain period of time. However, if the recovered patient has not recovered in Hong Kong, but he has come into Hong Kong after recovery, what happens?
If we are aware of any confirmed cases that in which the patients have recovered somewhere else, we will, of course, have counseling and education work. Well, there must be some kind of liaison work with the WHO. Say, for example, recovered patients from in West African countries. For the sake of the health of people in the world, maybe they're advised not to leave the country or leave some kind of contact and details. What I'm most worried about is that when there is a case on the mainland with a frequent exchange between Hong Kong and China, then what if there is a patient coming to Hong Kong? Well, if you want to know what instructions the WHO has given to those affected countries, we will find out. And if you want to know about notification mechanisms for recovered patients, we will liaise with the National Health and Family Planning Commission. Well, I'm very disappointed with the WHO because, well, it's not very much different from 10 years ago, but I'm sure that the CEO of the WHO has her duties to perform. Well, are there any tracking mechanisms under the WHO? Well, we will find the information for you. Dr. Zhang would like to supply information. When it comes to transmissibility of recovered patients, let me give you some academic information. We have the information because there was a study on the presence of the virus in the bodily fluid of recovered patients. We check the VCR of the patients. We're talking about a really close contact, say, for example, semen and breast milk, milk from mammary gland. Because antibodies of the patient may not penetrate deep enough in these organs. So even if the VCR comes up positive, we're not able to culture the virus. So it's an academic discovery. There is a low transmissibility, and we're talking about bodily fluid that is deep inside the body. And when it comes to Ebola outbreak, we target patients presenting symptoms. Well, we need an explanation before we know better. From the press release, all we know is that the virus may survive for 7 weeks in a recovered patient. Mr. Albert Chan, when it comes to Ebola, we understand that transmissibility is different from SARS. There will be smaller chance of transmissibility, but we should not underestimate the impact. The public only gets a partial understanding of the disease. There are a lot of images. we're bombarded with many different images from various channels, and it causes fear. How about using government airtime to enhance your education? Say, for example, what symptoms warrants special attention, and some more education material. In this way, people won't be as this will reduce the chance that the public may panic, and it will also enhance our preparedness in relation to an outbreak. So can there be an API produced to disseminate the information? I've just spoken to the doctor on enriching the content of the publicity material, and to enhance the information disseminated in our API. When will they be produced? We can't tell you when. Well, once they have been produced, can you inform the panel? Once we know when the API will be produced, we will inform you. Can the administration tell us this? Should patients present with compatible symptoms, they should go to Princess of Margaret Hospital. For suspected cases, we will transfer the patient to Princess Margaret Hospital, but the public may not be in the best position to distinguish. So even if you use the ambulance, you'll be sent to the closest A&E, and we have medical staff who are able to tell. If you ask the public to distinguish, I think there will be a lot of patients going to the Princess of Margaret Hospital. Ms. An Chang. You know that Ebola is a deadly disease. So we should err on the cautious side. Is it the case that there are sporadic cases in other countries? For other countries, say Spain, US, they are imported cases from West Africa. So there is so it has not spread. If there is any local case or imported case and there is a community transmission, then it will be defined as infected community. For Nigeria, that is the fourth affected country, from the information I gather, I think there is a patient from, I think, Liberia that has gone to Nigeria, and all the infected patients are infected as a result of the Liberian patient. There is one imported case, and then the disease spread. And that's exactly what I'm worried about. Hong Kong is a small place, densely populated. There are a lot of African people who like to come to Hong Kong. So we have to be vigilant. And I'd like to ask about bodily fluid. What about exchange of saliva? Will you get the disease from kissing? For a patient with symptoms, yes. So, is highly transmissible. Oh, well, if you put it this way, yes. But what you said is a very close contact. I will just give you some scientific data for your reference. I can sense that you think it is highly transmittable and is very dangerous. But when it comes to microbiology science, well, there is a definition. So from 1 transmitting to 10, then is highly transmissible. But the recent scientific data for Ebola is 1 to 1.8. That is the basic reproductive number. What's SARS? 1 to 3 something. A different set of figures. In the last outbreak of Ebola, Congo, 1995, 700 patients or so. Literature show that there are 173 family members who have been affected. And they live together, they share the same bed, so it's not highly transmissible. What I want to know is whether there is a working group following up on Ebola to gather information, to make contact. Yes. Who's the head of the team? The chairman of the Infectious Disease Control Center of the HA, Dr. Liu. Miss Priscilla Leung. I'd like to know, you talk about bodily fluid. You said it covers sweat. And a member asked whether it can be transmitted through kissing. And sometimes it's not lovers. For a continental kiss, well, you kiss on you give the other person a peck on each cheek. And there is a skin contact. And when we visit the district, we shake hands. You talk about a bodily fluid. Does the public understand fully? Well, for blood, yes, then they know that there is a specific means of transmission. Will you consider stepping up your publicity and education? And I'd like to ask, for AIDS, for the general public, we think that is highly transmissible. Is it the case that for Ebola, the transmissibility is low? If someone has a very robust immune system, then you won't get the disease from shaking the hands of the patient because the hands are sweaty. What about people from Africa? Will you give us more advice? We don't want to see a situation in which people flee when there is such a person being present. In the CHP website, you will find and all the information available on Ebola, including mode of transmission, and we will put more information on it. Well, I think it may not be as desirable if it's only available on the internet. That will be the central dissemination point. After well, of course, we will include all information we have. If you would like to know more about the mode of transmission, say, for example, a peck on the cheek, whether you will get the disease, well, I'll see if Dr. Zhang have anything else to add to that. I'll deal with this in an academical way. First, for the disease to be transmitted, there will be a source. Well, WHO said that there are 4 affected countries with acute transmission. So that if there is no source, you don't have to worry. And you're talking about a mode of transmission. Without a source, you don't have to worry. Well, you said that it can be transmitted through sweat. You can easily come into contact with sweat. Excuse me. If there is no broken skin, if the skin is intact, then and there is no contact with the mucous membrane, there is no risk of transmission.
That is why the Secretary said that environmental hygiene and hand hygiene should be watched. If the other person is not the source, then there will be no problem. But what if he is the source, or he is an index patient and he kisses you 3 times on the cheek? Well, then he should be isolated. Well, I'd like to get that clear. Mr. Chen Han Pan. Thank you, Chair. According to some reports, the WHO has said that this is an outbreak which is the most serious for the last 40 years. There is a high number of deaths, and infected patients are increasing in number day by day. In different countries, they have taken different measures, like the US, South Korea, and also Taiwan. They have issued travel alerts. In Hong Kong, we have not included health as part of the OTA system. Will your bureau work with the SB to come up with that kind of travel alert to remind Hong Kong people that if they are going to these places, they should pay particular attention? Secondly, we know that the OTA covers 85 countries frequented by Hong Kong people, but this is a special situation, and the US is actually recalling his citizens. But should we just stay passive or take more active measures? Secretary, I think I can just repeat what we have said. We already have the alert system. Whether it be the CHP or the Security Bureau, they have already issued the advice to Hong Kong people, and I myself has said that many times. We have said very clearly to the Hong Kong people that if it is not absolutely necessary, don't go to the affected areas or countries. So we have issued the advice. Any follow-up? Well, as I said, I'd like to know whether we can do other things more actively. For example, can we liaise the Chinese consulate in those places? Have we done that? Or will you recall Hong Kong citizens from those places? Secretary? Generally speaking, we contact the representatives of those countries in Hong Kong, but it seems these countries have yet no representatives in Hong Kong. So we are mainly liaising with our travel industry to do publicity and education for them. And also the airport authority has done a lot. They have done exercises and drills. We have also given them talks and explanations. Okay, no more questions? Any more questions? Miss Anne Chang? Miss Anne Chang? I know that Dr. Koh and other doctors have said this, that there is yet no recognized drug if Ebola should be found in Hong Kong, and we can only use medication that is still being tested. If that's the case, if unfortunately there is an EBD case in Hong Kong, then is it that we would start looking for the drug then and then order the drug only when we have a suspected case? Or are you going to order a small volume of the drug now? And also, I'd like to know when there will be an onset after infection. The last question, I can answer that. You are actually talking about the incubation period, which is 2 to 21 days. As for your first question, you are talking about medication. We are not just sitting here to wait for any cases to happen. We are actively contacting pharmaceutical producers and also the WHO, asking them if we should need the medication, what should be done. And as I said, there is a type of medicine which is already here, but it is not used for curing EVD but other diseases. And if it can be used also helpfully for EVD, and after our experts have discussed it, and if the clinical team wants to use it, then that medication is in Hong Kong. Are you talking about the breast cancer drug? Well, a similar drug. Yes, we have it in Hong Kong. I think it is a drug related to fertility. For how long the virus can survive in a natural environment, that is away from the human body? For how long can the virus stay alive in a natural environment? Basically, it's an RNA virus. It can degrade easily after leaving the human body. There has been an experiment done that a patient is in a room and then an environment sample is taken. But there is also a disinfectant, so there is none in the environment, but we can find the chain reaction through getting a sample from the clothes. But it is not a germ, it is an RNA virus, so it cannot survive for very long. Okay, there are no more questions. You talked about the survival period of the virus after leaving the human body. For how long? I think a few days. It is not bacteria. Bacteria can survive for 1 month, 2 months, but this one is a virus. It has a short survival period after leaving the human body, but a few days is a long period. Well, we are drawing a comparative comparison with bacteria. If there are no other questions, I'd like to thank the Secretary and his team for coming. I believe the administration has got a lot of experience, and I'm sure it can tackle any conditions. Well, let me summarize. Should we be worried? Yes, we should be worried. Should we be afraid? No, we should not panic. Will there be Ebola cases in Hong Kong? There is a possibility, because there could be cases introduced into Hong Kong. We are an international city, and that possibility exists. But given our present medical system, we have the ability, even if there is an introduced or imported case, there could be early identification and early isolation and early treatment so that there will not be widespread outbreak in the community. Okay, no more questions. Thank you very much.